academic year, rounding out the end of the quarter for many of you who are teaching. And so I know that there are a lot of places that you could be right now. So thank you for choosing to spend your afternoon with me. I'm going to go ahead and share my screen and we'll jump into it. And I'll give a presentation and then we have lots of time for some engaging discussion and Q&A at the end. All righty. Okay, so can I confirm that you guys are able to see the correct version of slides? Okay, perfect. As mentioned today, I'm going to talk about using equity science to address racism as a public health crisis. I will make one minor correction that she introduced me as associate professor. I have another 30 days of probation. And then on July 1st, I will be associate professor of emergency medicine with tenure, but I have been celebrating since I got the letter from the chancellor preemptively. But as of July 1st, I will only be responding to Tenny Tiff is what you guys can call me, effective July 1st. But thanks again for being here. I was asked, just in case there are some students or postdocs on the Zoom today, in addition to talking about my research, to talk a little bit about my journey as well. And so I won't talk about my entire life. I know it looks like it based on this first slide, but I will acknowledge some of the influences that, some of the factors that influence my career and the work that I do. So I am the daughter of Kathleen Smallwood Johnson. And that's my mama's high school yearbook picture there. My mother was, she had a background in education and then went on to law school when I was a little tot. So I have very early memories of being 2 years old, like sitting at the kitchen table doing my homework while she was doing her law school homework and going to law school with her. And she initially worked as a public defender in Newark, New Jersey. And so I learned a lot about advocating for underrepresented and underserved and disenfranchised populations from the work that she did as a public defender. She was a single parent, so anytime that school had a day off, but the courts did not have a day off, I was sitting in court with her while she was defending drug addicts and prostitutes and all kinds of other humanity, but knowing that they deserved a right to effective counsel as well. So I learned a lot from her. And then from being a public defender, she then used her background in education and went on to become an attorney for the Trenton Public Schools. And so I also learned a lot about advocating for children through her. And when she started working for Trenton Public Schools, she moved me from Montclair, New Jersey to Trenton, New Jersey, and moved me from really amazing public schools to really crappy public schools that she was advocating for. And so that also has influenced a lot of my journey, being exposed at such an early life to inequities in the education system, being within the same state and seeing the differences in resources and quality of education. And my mother is the daughter of Catherine Bell, who is here in the middle. Bell was actually her modeling name. So Catherine Smallwood Harris was her name. She was a jet beauty model. She loved to read. She loved to party. And I like to put her in here to remind me because I can be really serious and overwork. And my grandmother reminds me to tap into my inner sassy self and to have fun and to embrace some Black joy in my life. And then she was the daughter of Serena Smallwood, who is my great grandmother. Now, my grandmother, I'll also say, because this definitely influences me and who I am and what my work is. My grandmother was murdered at the age of 38 when my mother was 17. So I never met her. But my great grandmother was in my life until she passed away at 13. My great grandmother was born in Plymouth, North Carolina. When she was 13 years old, she was raped by a group of white men. And that is how she got pregnant with my grandmother, who she had at the age of 14. And when my grandmother was about 10 years old, as she was entering into that early adolescent period, she moved her to the north so that she can protect her from the things that she experienced and so that she could try to provide a better quality of life for her. My great grandmother, Serena, she dropped out of school when she was in the 4th grade so that she could work on the tobacco farm to help support her family. And, you know, so she dealt with a lot, but, you know, I just knew her as Nana, and she cussed a lot and she fussed a lot, but she also was incredibly loving and supportive towards me. And, you know, she cleaned the houses of white doctors and didn't get to see me become a physician, but I know that she's looking down on me now. And so I think that this is important because, you know, this lineage, like their trauma courses through my veins, but their resilience also courses through my veins, and it influences a lot of the work that I'm doing. I also say that I come to academic medicine as a daughter, a sister, a friend, and my favorite title, best auntie ever. I come as a Black woman, and that certainly shapes my perspective and my experience and the contributions that I make to research. And I keep those two attached together because those intersecting identities can't really be disentangled for me based on what my lived experience is. I'm cisgender, heterosexual, and I use pronouns she, her. I have a lot to learn about being a good ally for the LGBTQ community as we are in the first day of Pride Month. And I mentioned I'm the product of urban public schools. I experienced, as you can imagine, I talked about some of my family's experiences, but I also experienced more than 4 adverse childhood experiences. And we know that greater than 4 is associated with significant disparities in mental and physical health outcomes. And I'm also a lover of Black coffee and Black culture and Black people. So although I have no financial disclosures to make to you guys today, I disclose these different identities that have influenced who I am and the perspective that I bring. And I think that these diverse perspectives are really important to have richness in academic medicine as well as in research. So I'm going to talk to you guys today about just my journey in my early career in research. And it's an ongoing journey using equity science to help address racism as a public health crisis through 4 different phases of research. So my early career has really been focused on identifying racial disparities in pediatric healthcare and outcomes and understanding the root causes of those disparities, which has focused on investigating and describing racism as a root cause. And now as I am transitioning into my mid-career, which officially starts on July 1, I'm better positioned to focus on developing and testing interventions aimed at reducing disparities to advance child health equity, as well as the translation of both my research as well as my lived experience to use them as a tool for advocacy. All right, so first we're going to talk about some of the work that I've done to identify disparities. So this figure comes from the National Academy of Medicine report Unequal Treatment, defining healthcare disparities as differences in the quality of healthcare that are independent of patient need and clinical appropriateness, but they occur due to factors at the level of the healthcare system and the legal and regulatory environment in which healthcare systems operate, as well as factors at the level of the healthcare provider, including discrimination, bias, stereotyping, and clinical uncertainty. So it was really this report Unequal Treatment that helped to guide a lot of my career and my early research in some of those factors that I was looking at as root causes. So especially for those who are trainees and postdocs who are on the call or students, when I started my research career, I wanted to just save the world one brown baby at a time. But I was lucky that I had good mentors that helped to rein me in. And so kind of starting off with smaller, discrete projects was really helpful for me to be able to build my career. And so, I talked about that National Academy of Medicine report, which was published over 20 years ago now. That report had hundreds of studies documenting disparities in healthcare and outcomes for minoritized populations, but it only described 5 pediatric studies and no pediatric emergency medicine studies. So, and I think a lot of times pediatricians, we think we're superheroes, which we are, but we think that sometimes, especially early in my career, that meant that we were immune from having bias and that everybody treats, brown kids the same way as they treat white kids. And so it was important early in my career to really help define and describe some of the disparities that existed. So I'm going to use just a couple of examples, particularly as we talk about kind of those phases of research for how I used identifying disparities to work towards either interventions or really work towards translating them into advocacy, more focused on that lowercase p policy, so policies at hospital, institution, academic levels, and not necessarily uppercase p policy at the state or national level. But so this one study was looking at disparities in pediatric emergency care, which really has been an area that still remains very understudied. Although one of my colleagues here, Daniel Nishijima, is working right now on getting a paper published looking looking at disparities in pre-hospital pain management. But early in my career, I did this analysis of children who were transported by a critical care transport agency for injuries, looking at analgesic use. And what we found was that overall, they were doing a pretty crappy job across the board at analgesia for children in this agency. So looking at pain score documented, 41% of white children had pain scores documented in comparison to 27% of non-white children. And for analgesics administered, only 15% of white children and 10.4% of non-white children. Interestingly, although there were these big gaps in the unadjusted analysis, when we adjusted for important confounders in this, including patient age, IV access, what type of transfer, and other clinical factors, those disparities went away. So we really tried to get at, well, what was driving them? And one of the things that was that this was a critical care transport agency that primarily transported adult patients. And so all of their policies did not have pediatric considerations in them. So for example, the primary analgesic that was being used was IV fentanyl, and they had guidelines that it should be given for a certain pain score, but their pain score was a 1 to 10 pain score, which is not appropriate to use in your younger children who can't developmentally articulate that. And then they also had a stipulation to not give it if the systolic blood pressure was less than 100. So for my non-clinicians and my non-pediatricians, most children, depending on their age, is clinically normal for their systolic blood pressure to be less than 100. So pain medications were being held based on these adult parameters. So we were able to use this research to make changes in the transport protocols for this agency so that they put in pediatric pain scales, so FACES scales for kids to be able to identify a face to correlate with their pain. And then they also put in pediatric parameters for administering and withholding analgesics based on blood pressure and other vital signs. So this is just one example of how, we identified a problem in just overall poor documentation of pain score and administration of analgesics, and we were able to address it by changing the protocols to make them more pediatric specific. So next, there were a couple of studies done in my early career at the Children's Hospital of Philadelphia using quality improvement data. So interestingly, CHOP is really one of the leaders in pediatric patient safety and quality improvement. But prior to this work, they had never looked at whether or not there were disparities in the clinical care pathways in their QI portfolio based on race, ethnicity, language, or social economic status. So there were a couple of studies done, one that identified racial differences in sepsis management, and sepsis recognition in the emergency department, which found that when you had a pathway in place and an alert for sepsis, there were no disparities. But for patients who were put on a sepsis pathway based on clinical discretion alone, white children were more likely to be put on that pathway in comparison to Black children. And so that was an example of how when you have very objective guidelines, the disparities kind of get washed out. And when it's just based on clinical judgment, we see more discretion and more disparities that exist in care. The second one, interestingly, was based on children in a clinical pathway for the management of gastroenteritis and dehydration. And so here you had very clear guidelines about when IV fluids were indicated and when they weren't. And despite having this pathway that exists in order to reduce variability in care, we still found that in comparison to white children, that the Black, Hispanic, and other race children were less likely to receive IV fluids or be admitted to the hospital when presenting with similar symptoms of gastroenteritis and dehydration. So the importance of this work is that, at the time that we started doing it, it was making folks feel really uncomfortable because they didn't want to identify the disparities that existed in care. And so this led to integrating with the Patient Safety and Quality Improvement Program to develop an equity subcommittee to really help just destigmatize the equity work. And similar to the early QI work where nobody wants to publish data on poor quality, but they're working on improving quality of care, recognizing that reducing disparities is an important component of patient safety and quality improvement efforts. And how do you get individuals who have expertise in disparities, as well as QI analysts, as well as clinicians, all at the table, so that when QI programs are being developed, they're being developed with an equity lens as opposed to trying to retrofit things and really trying to center programs around the margins. So again, another example of how some disparities were identified and working at the institutional lowercase p policy level to begin to address those disparities. And then finally, I'll highlight some work that's being done in the PCARN network. So PCARN stands for the Pediatric Emergency Care Applied Research Network. This is a network of 18 hospitals across the country that are doing cutting edge research to really improve the quality of care for children who are presenting to emergency departments for medical and traumatic emergencies. And I collaborated with a team studying healthcare disparities using the PCARN electronic health registry, which is a database that initially included 4 of the 18 sites with 3 of the satellite centers and has been continuously growing over the years to add in so that we will eventually get to the point of including all of the sites. But what we found in some of this early work in the PCARN registry was that if we looked for disparities, we found them. And this is, I think, particularly important because a lot of research looking at disparities in emergency care has either been single center research or has been research using large administrative databases, but we kind of have found a sweet spot in between where we have a large sample size of multiple hospitals, but we also know who those hospitals are so that as we're identifying disparities, we can more effectively get to that point where we're able to develop and test interventions. But some of our early findings included disparities in antibiotics for viral illnesses, disparities in giving pain medications for children getting fractures, disparities with more delayed diagnosis of appendicitis for children who are Black and Hispanic, as well as disparities in the length of time that children wait to be seen by a provider when they first come to the emergency department. So this collaborative research has been important because it's led to the development of a disparities working group that is really seeking to expand the portfolio of disparities research and equity efforts within the PCARN network as a whole. So our vision is that PCARN will be a leader in advancing health equity and workforce diversity through rigorous, high priority, multi-institutional research focused on reducing avoidable disparities and ensuring that all children can achieve their fullest level of health and well-being. So the Disparities Working Group and a couple of my colleagues are on now who are leaders in PCARN. So Dr. Nate Cooperman, who's my department chair, who's one of the founding fathers of the PCARN network, and he leads our node. And Dr. Leah Zeminatos, I see, is also on here, and she is the PI of our site within PCARN. And they are also both involved in this Disparities Working Group. And this year, our working group set 3 goals. So the first is developing priorities for disparities in pediatric emergency care research agenda so that we can really see how we can better leverage the network to address important questions around disparities. The second is identifying core data elements for addressing disparities that should be included in all PCARN studies. So this came up because we found that as we're doing some of these like retrospective studies, looking at some of the original PCARN data and looking for disparities later, there are times where there are critical things that should have been included that weren't included just because of benign neglect. So for example, I mentioned my colleague Daniel Nishijima is working on a paper now looking at racial and ethnic differences in pre-hospital analgesia. But in order to do that, when they initially collected that data, patient race was not a variable that was being collected. And so they had to go back and get that variable in order to be able to look at disparities. And so we want to make sure that if PCARN is going to be a leader in general in pediatric emergency care research, we can't achieve excellence and have excellence without also addressing issues around equity. And so it's really important that every study collect a core set of data elements to make sure that we're able to look for inequities in care. And then our last goal is, so one of a part of the secret sauce for PCARN and why it's so successful is because before studies are submitted to the NIH or other grant funders, they first go through the gauntlet of PCARN and get beat up by several subcommittees that help to review the study and provide feedback. So we've gone through the process this year of taking all of those forms from the different subcommittees and incorporating questions around whether or not the investigators are considering the equitable inclusion of underrepresented and understudied populations, as well as generating knowledge about disparities that may be influenced by social determinants of health. And it's been great to see this process because in our last steering committee meeting, each of the new protocols that were being presented, the investigators had a slide on equity, which is not something that we were seeing even one meeting ago, 3 months ago with the last meeting. So this is an example of the impact that you can have when working through the policies and procedures within your institutions and your organizations for helping to advance health equity. All right, so next I'm going to describe kind of the second phase of my research in my early career, which is understanding the root causes of disparities. And so these studies really are also going to help show that, how do we identify the problems which are going to be needed in order to begin developing and testing some of those interventions. So we talked about that report from unequal treatment and some of those areas that they identified as, defining kind of where disparities arise from. And so a lot of my early research focused on looking at implicit bias, which is a measurable way to look at factors that might be influencing disparities in care. So the way that I did this is using the implicit association test. So the IAT, for those who are not familiar with this, is a validated tool. It's a timed categorization task where you're shown pictures of Black faces and white faces and words that represent good and bad. And so in this example, you have white or bad, Black or good. So when the Black face comes up, you would link it with Black or good. If a white face comes up, you would link it with white or bad. When joy comes up, you would link it with Black or good. When terrible comes up, you would link it with white or bad. And they randomize the order of these categorizations. So one trial will have white or bad, Black or good. Another trial will have white or good, Black or bad. And what they do is they look at the number of mistakes that you make when you're rapidly sorting these. And they also look at your response latency time. So if it's easier for you or you make less mistakes, you're able to do it more quickly to when the categories are white or good, Black or bad, but it's harder for you for this counter stereotypical association of white or bad, Black or good, then you have an implicit pro-white, anti-Black bias. If you haven't taken an IIT, I wish I got $1 for every time I told someone to take one, but I have no affiliations with Project Implicit. But I would encourage you to log on to Project Implicit and explore some of your implicit biases. So I'm going to talk about one study that looked at just this standard race IAT. And this was really my first step in moving beyond documenting disparities towards beginning to understand their root causes. So this first study is looking at the impact of cognitive load on implicit bias. So this was a study that was done with 91 residents working in a pediatric emergency department. So most pediatric EDs, you have your pediatric residency trainees, as well as general emergency medicine trainees, and then a smattering of other specialties like psych and family medicine. And so we gave each of the participants an IAT before a shift and after a shift, and we actually randomized it so that to counteract the practice effect. So half of the participants got their first IAT at the beginning of the shift, and the other half of the participants got their first IAT at the end of a shift, and then took the second one at the beginning of the next shift. But what we found was that among participants who took care of more than 10 patients in the emergency department, their pre-IAT shift score, IAT score was 0.46. Their post-shift IAT score increased to 0.63 for a mean of 0.17 that was statistically significant. We also found that when residents worked, so we use number of patients as a proxy for how busy you are, but then there was also an objective measure, something called a NEDOC score that looks at overall emergency department kind of busyness and overcrowding. And we found that when residents were working during a shift where there was a higher NEDOC score, the ED was more overcrowded. We also saw then an increase in their pre to post-shift IAT score that was statistically significant. But there are also factors that may be more likely to exacerbate your bias. And so when I'm working in the emergency department, I don't always follow this myself in COVID times because I wear N95 all shift, but I like to make sure that my residents all eat, drink, and pee before the end of their shift, right? Because if you can help reduce that cognitive load, then you're going to be a better doctor for your patients as well. And so next we looked at bias towards adults versus children. So I showed you the standard race IIT, which shows these pictures of quite frankly, very scary looking Black people and very scary looking white people. Like I wouldn't want to go to dinner with anybody in this. Like they just look super scary. But I'm a pediatrician and I take care of super cute kids, not super scary looking adults. And so there's this child race IAT that was actually developed to give to children to determine when children's biases and how they change over time. But when I saw these super cute kids, I thought, oh my goodness, I'm going to give this IAT to these residents. And this is where my biases are going to come out. And I'll tell you that my biases have changed. So at the time that I did this study, I was working in a children's hospital and I was like, pediatric residents are the best and they're going to kill it. They're going to nail this. They're going to do so good on this child race IIT. And those general emergency medicine residents, they're so jaded and they're going to do really bad on it. I'll say interestingly, like our biases can shift and change over time, right? Because now I work in a general ED and I'm much closer to the general ED residents than the pediatric residents. And so my hypothesis might be different if I were doing this study here from UC Davis versus in some of the other settings that I was working in. But my hypothesis is basically like, everybody loves brown babies, right? So you may have these negative attitudes about the parents that are in the room, but you're going to have less bias towards children. But this is what we found. So the adult race IIT scores are in pink and the child race IIT scores are in brown. And we found that overall, the mean IIT scores were not statistically different for the child versus the adult race IIT. We found that 85% of all the residents, the 91 residents that took the study, had bias against Black adults, and 91% of all the residents that participated in this study had bias against Black children. And we also, when we looked at by demographic characteristics, there were no differences in bias based on whether it was a pediatric resident or emergency medicine resident. There were also no differences based on whether it was a female resident versus a male resident. So this study was really enlightening for me. And I think the people who have read it to show that, number one, the children who are, our most innocent and vulnerable population, they're not immune from experiencing bias, even from providers who self-select to go into taking care of kids. And that, pediatricians, even though we're superheroes, we're also human. And going to medical school and doing pediatric residency does not make you immune from having bias, nor do we self-select people into our specialties that are unbiased. So everybody has bias and we all have work to do. And so this is a part of a growing body of evidence looking at implicit bias in a healthcare setting. A few years ago, I published a systematic review with one of my med students looking at a decade of studying implicit bias. And what we've learned is that most healthcare providers are very similar to the general population, and they have an implicit bias favoring white over Black, Hispanic, as well as some studies have been done with Native American populations. There's also a really robust body of literature showing that not only do we have bias, but that bias impacts doctor-patient communication, both our verbal as well as our nonverbal communication skills. And there's also some evidence that shows that bias impacts our medical decision-making in the healthcare setting. But as the research on implicit bias in healthcare continues to grow, I think it's really important to highlight that the associations that one holds towards a group of people, they don't exist simply because of in-group versus out-group preferences, but instead they're rooted in a history of policies and practices that are reinforced through priming and association. So therefore, any discussion about implicit bias is really important that it's also anchored in an understanding of the ways in which these biases were strategically cultivated through white supremacy and continue to be reinforced through structural racism. So, now my friend Thomas O'Donnell was just telling me he's a history buff. So this is for you. So a very brief history, right? I can talk for hours. We can have a whole semester class on the history of racism. But briefly, it's important to acknowledge that race is a social construct and not a biological construct, and it's been closely tied to the concept of white as superior, serving as justification for colonization as well as the enslavement of African people. And unfortunately, medicine and science, I'll use science in quotes because there's been a lot of pseudoscience, has helped to legitimize this narrative, publishing on Black genetic inferiority. So for example, it was a physician who coined the term drapetomania, which he defined as a mental health disorder among enslaved Black people with symptoms including the urge to run away, to destroy property, to disobey their slave masters, to talk back to the enslavers, and to refuse to work. And enslavers were encouraged encouraged to whip enslaved people and to keep them in the position of submission that they were intended to occupy as a form of prevention and therapy. This is a physician who said this. And this racist rhetoric of Black genetic inferiority proposed by the medical community, it really served as justification to uphold slavery and to uphold white supremacy. And the eugenics movement subsequently codified the disproportionate forced sterilization among minoritized groups to help prevent the spread of violence, promiscuity, substance abuse, and intellectual inferiority, which was stereotyped as existing among descendants of African people. This is another example in the mid-18th century of a scientific explanations that were emerging regarding differences between people who are African versus white European and American. So for example, researchers measured skulls across different races and concluded that African people had smaller skulls and were therefore less intelligent than European and white people, and really sparking a dehumanization of people from African descent. And I think it's important to understand that not only is there this historic context of dehumanization, but this is something that also continues to exist in modern times. So these are some images that we see in the media that can serve as primes that further reinforce the racial biases that we have. And here's one this is from an ad for a clothing store where this cute little Black boy is labeled as the coolest monkey in the jungle. And these primes help to trigger some of the negative associations held about Black people that physicians hold even today in the 21st century. So for example, this tweet is from just a couple of months ago, where a psychiatrist at a prominent institution in New York, in response to a tweet about this beautiful Black woman, he tweeted, "Whether a work of art or a freak of nature, she's a beautiful sight to behold." And so if you are someone who looks like this beautiful Black woman, I can't imagine what your experience will be like going into healthcare if you have a provider that doesn't see you as someone who is a reader, who loves reading the newspaper, or as someone who is a model, someone who is a mother or a daughter or a sister or a friend, but sees you as a freak of nature because of the color of your skin. And racist imagery and priming has also even been used in pharmaceutical marketing. So for example, this is an advertisement in the Archives of General Psychiatry from 1974, featuring this very angry looking Black man who's shaking his fist, captured, "Assaultive and belligerent, cooperation often begins with Haldol." So when we consider this IAT that we talked about, the implicit associations that Black, Hispanic, and Native faces with bad, like terrible, horrible, evil, awful, agony, hurt, these associations don't occur by chance. Instead, they were created by design, and they've been reinforced by means of priming via popular culture, news and media, and even our government. And so it's therefore by design that Black people are viewed as violent and less intelligent and lazy and dehumanized and likened to animals. And such mischaracterizations of minoritized groups historically helped justify policies like the slave codes and Jim Crow, and more recently, the war on drugs and our immigration policy. And even the way that we've seen law enforcement interact with different protesters, whether they are, Trump supporters versus Black Lives Matters protesters. So this is why it's really important that any discourse on implicit bias is rooted in our understanding of structural racism and acknowledgement that these bias associations that we have are due to strategic priming, history, policies, and practices. And so as a pediatrician, kind of grounding this work on implicit bias and marrying it with structural racism, my work over the past few years has really tried to highlight the impact that structural racism has on child and adolescent health, recognizing that if we take a social determinants of health standpoint, racism impacts where children live. It impacts where they learn. And I told you a little bit about my experience with how it impacted where I learned in the education system. It impacts what they have, including access to safe playgrounds and nutritious foods, as well as economic opportunities across their life course. And it impacts how their rights are executed with over-policing of Black and Latino communities and police violence, particularly anti-Black police violence. So because of this, over the past few years, I've been extending my research on implicit bias in healthcare to also begin looking at bias in the healthcare system For example, this is a study that we just published just maybe a month or two ago, where we measure implicit bias of teachers and staff from 3 urban healthcare centers using the Child Race Implicit Association test. And what we found was that actually the participants were a little bit less biased than our pediatricians in this, but 60% of the participants had an implicit pro-white, anti-Black bias. But interestingly, in contrast, despite 60% having an implicit bias, 95% of participants reported on explicit measures that they had no preference for Black or white children. And this work is particularly important because there is a growing body of research showing disparities in disciplinary action. So we have children as young as preschool being suspended or even expelled from school. And we also see other disparities in important educational outcomes for youth. So important to understand both what the structures are in place in institutions that are contributing to these disparities, as well as the role of implicit bias among the people who are both developing the policies as well as implementing them and educating our students. So in addition to education, as we kind of take the social determinants of health approach to racism and how it impacts child health, I've also provided some content expertise as a senior author of this narrative that integrates a multidisciplinary scholarship approach to illustrate the relationship between racism, poverty, and health, and looking at kind of that intersection again with social determinants and how it impacts where children live, learn, and they play. And in this paper, we provide some suggestions for effective anti-poverty solutions that must account for privilege and power inequities and seek to redistribute that power and those resources through policies such as reparations, decarceration with support, as well as equitable education and recreation funding and spaces for children. And we can't discuss racism as a public health crisis without discussing anti-Black police violence. So there is a group that includes pediatricians called PART, so Pediatricians Against Racism and Trauma, a multidisciplinary group of pediatricians across the country that are kind of a step outside of the traditional academic organizations that came together to write this commentary after the murder of George Floyd, providing again some policy suggestions for how to address anti-Black police violence as a public health crisis. And then this later led to an in-depth review that I published last year detailing the evidence of how both direct and vicarious experiences of police violence can impact youth, not only through increased morbidity and mortality, but also impacting their academic, behavioral, and health outcomes. And again, making some recommendations for how pediatricians can begin to address this public health crisis through clinical practice education, advocacy, and research. But I think for this paper, one of the important things for me is that beyond the disturbing statistics of police-related deaths, recognizing that is the #1 cause of death for young African-American males, as pediatricians, it's also important to highlight the humanity of these children and adolescents as our patients, right? So an example is 17-year-old Antoine Rose, who was a passenger in a car stopped by police, who was shot as he ran away from the scene unarmed. He was the actual patient of one of my colleagues in Pittsburgh, who was an adolescent medicine physician. And I think when we see these stories on the news, we see them as statistics and forget that they're actually humans. And we really need to honor these lives taken as our sons and our daughters and our sisters and our brothers. In some cases, they're also, these young people are mothers and fathers. And we must acknowledge the dreams and the potential that's been unrealized, such as Trayvon Martin, who had dreams of becoming a pilot before he was killed at the age of 17 by a neighborhood watch volunteer, or Breonna Taylor, who was a 26-year-old EMT and an aspiring nurse who was shot to death while in her bed by police serving a search warrant related to a narcotics investigation of her ex-boyfriend, who was already in custody at the time. And after her death, a grand jury indicted one officer for wanton endangerment, not for the shots that killed her, but for the 10 shots that were fired and missed her and passed into her neighbor's apartment. And so it's important that we say their names, including names like Stephon Clark, who's pictured here, who was murdered right here in Sacramento by the police when he was unarmed. And this paper also provides some suggestions for policy level recommendations, again, as we think about these phases of research and how you translate research and lived experience into policy and advocacy. Importantly, it's also worth noting that there has been a lot of discussion and a lot of debate and a lot of public statements about Black Lives Mattering post the murder of George Floyd, Ahmaud Arbery, and Breonna Taylor and others. But in healthcare, I think it's also important to acknowledge the harmful effect of policing that can happen right within our own healthcare institutions. And so there's been some growing evidence showing that Black patients are more likely to have security called on them while they're in healthcare. There have been some high profile shootings, and including one in an emergency department in Southern California, where a patient was murdered by the police while he was in the hospital, having a psychiatric emergency. And that's one of several cases that have been reported. And so I think it's also important for us as we're thinking about how we can advocate for our patients, how we can take that look within and be reflective. And, we were having some pre-conversation before we got started about, some of the work that's being nationally and how we can apply that to UC Davis. And I think these are examples of thinking about what is happening here within our own homes and with our own hallowed halls. And I'll use one example of a successful advocacy approach was that I can't remember if it was a year or two ago. Time is all melting together. I think it might have been 2 years ago. The UC Davis Police Department decided to deploy a K-9 unit that started within our own emergency department. And so to have literally like right on the heels, the same month as all the protests are happening around the murder of George Floyd, they decide to bring a police dog into the emergency department. It was a pretty tone deaf decision for security to make. But we were able to leverage some of the science around like what's been known about the disproportionality around K-9 involvement for peaceful protesters, as well as even involving citizens who have some law enforcement involvement, as well as a patient experience early on with that. And we kind of came together for our DEI group within the emergency department and escalated it to the leadership. And the leadership, as a result, removed the K-9 from the emergency department. So I think that this is an example of successful advocacy for when there are things that you have unintended consequences, and when decisions are made without an equity lens, not considering the potential impact on vulnerable and underserved populations, to come into a therapeutic environment to see a police dog patrolling the hospital corridors, and how we were able to advocate to get that removed so that we can protect our patients in the emergency department while still making sure that we're keeping our staff safe. And so I'll, as we round out understanding sources of disparities, I'll just briefly mention some of the ongoing work that I'm doing looking at root causes of disparities. So I think it's important to recognize that team science is really essential to addressing disparities in the structures of racism that serve as barriers to child health equity that I seek to change across multiple domains. So I've been able to successfully form some research partnerships where I'm serving as the lead disparities investigator for some NIH funded grants. This group, we have 2 grants, one that is led by Dr. Tapia and one led by Dr. Williamson, that have recently been funded looking at pediatric sleep disparities and really looking at some of the social ecologic factors contributing to these disparities, including parent level factors like parenting style, family stress, family factors like adverse childhood experiences and chaos, as well as neighborhood characteristics like noise and neighborhood disadvantage, and also looking at the role of how experiences of discrimination within society, within healthcare, within schools impacts disparities in sleep and sleep disorder breathing for our pediatric patients. So I'm excited about what is to come from this work for understanding some of these root causes and really beginning to do deeper dives and looking at kind of structural racism and how it impacts health outcomes for our patient population. And then I am involved in one study now that I'll share that is focused on developing and testing interventions that reduce disparities. And so I put this picture here as a reminder to myself to mention, especially for the kind of junior faculty, trainees, and students who are on the call. So this is Mary Clyde Pierce, who is the PI of the study that I'm involved in. And so I met Mary Clyde when I was interviewing for fellowship at Lurie Children's. I chose not to go to fellowship at Lloyd Children's, and I did my fellowship in Pittsburgh, but we stayed connected. And this is from this past PAS, but every PAS we take an annual photo together. We have literally for like the past 10 years. And we sit and we meet and talk about, we've always wanted to collaborate and could never find the right fit or the right time. But I guess maybe this grant was submitted in 2019 when I first got here to UC Davis. We finally found a great opportunity to collaborate. So Mary Clyde Pierce is a child abuse researcher. And so she recently finished an R01 where she developed a clinical decision support tool to help distinguish for children who are under 2 who can't, when they come in injured and they can't tell you how they got injured, so you don't know if it was abuse versus an accident. She helped develop a clinical decision support tool to distinguish accidental versus abusive fractures. And now we have an R01 where we're validating that tool, but we're also looking at disparities that exist in child abuse evaluations. And so there's a robust body of literature that shows that when white kids present who are abused, they're more likely to be missed and less likely to get that initial evaluation for abuse and referral to CPS. And when Black and Hispanic children present for injuries that are very clearly accidental, they're still more likely to undergo an extensive workup, including things like skeletal survey, which is like dozens of x-rays, and reporting to child abuse. So we have these bi-directional disparities that result in poor outcomes for both patient populations. And so as the disparities lead, I'm investigating these disparities. I'm looking at root causes of those disparities, trying to understand the role that provider bias and attitudes plays in those decision-making. But we're also testing an intervention. So looking to see if this clinical decision support tool is used to decrease your clinical uncertainty around whether a broken bone is abusive versus accident. Will this intervention work to help reduce some of those bi-directional disparities? So I'm in the early phases of jumping into reducing disparities. And I've talked a little bit throughout the presentation about ways that I've tried to kind of translate some of this research into advocacy, mostly focusing at the institution and academic level. And I'll mention just a few more examples of how I've done that. And then I will take a sip of water and we'll jump into some discussion and some Q&A. So first I'll mention again, it's hard to talk about racism as a public health crisis without also talking about COVID. And so we know that there have been tremendous disparities identified in who's getting a diagnostic testing, who's contracting COVID, morbidity and mortality from COVID. As a pediatrician, children getting COVID, children getting multi-inflammatory syndrome in children who are losing their parents and becoming orphans due to COVID, as well as some disparities in vaccination, with a lot of very well-earned mistrust for the medical community. And so one of the ways that I've been able to use advocacy as a tool is partnering with PR here at UC Davis to have different forums with the community to try to serve as a trusted partner to begin to just answer their questions, to not try to pressure them into getting vaccinated, but to recognize that people are sophisticated, right? Even people with low health literacy are still pretty sophisticated, and they have questions that they want answered before they make any clinical decisions. And so how can we just be there? Oh, I have that same dress on today. I wouldn't have worn this if I knew I had a picture of me. I like to, switch it up, but I had that dress on when I was doing this. But I did change my hair at least since then, and my glasses for you guys. But providing some answers to the community to help address some of their concerns around getting vaccinated. And it was, as somebody who I still feel very new to Sacramento because I moved here right before the pandemic and the world has been shut down most of the time I've been here. And so I felt very honored that the community would trust me enough to be able to answer some of their questions around these issues. Another way that I've used advocacy and my lived experience is by publishing a commentary on an experience that was very painful and very hurtful for me, but using it as an opportunity so that I can take what I perceive as the take-home moments and teaching points, so that my Black colleagues who have similar situations in their professional networks, or students and trainees who are marginalized, who don't feel comfortable standing up because of their position intersectionality, I could be a voice for them. This paper was published the day before I went out on surgery for medical leave. And it was really nice being at home from surgery, recovering, and getting all of the emails pouring in from strangers across the country who said, that they read the article and identifying with having similar experiences and thanking me for being so brave for sharing them, as well as white allies who were horrified and felt compelled to begin doing the work themselves as a result of reading it and reporting, sharing it throughout their networks. So this is just another example of kind of how to use my experience for advocacy. And then I'll close on where we started in our pre-chat discussion, is using academic medicine. So I am a member of the American Academy of Pediatrics. I sat on their task force on addressing bias and discrimination, and I'm now a member of the Committee on the Psychosocial Aspects of Child and Family Health. And the AAP has been on a journey, that probably began right when that task force was seated on addressing bias and discrimination, and which was seated from 2017 to 2019, of really doing some internal looking and trying to figure out what can we as an organization do to help advance child health equity. Some important things that have come out of the Academy include in 2019, they published a policy statement on the impact of racism on child and adolescent health. And that publication was really a pivotal point for the Academy, because I will say prior to that, for example, when there was a cluster of police shootings, I believe in like 2014 or 2016, the Academy published a statement on the road to tolerance. And I remember reading that and thinking like, man, like, is that what it's come to? Like that the Academy is just going to tolerate me as a Black person and they just going to tolerate these Black kids. And I don't want to be tolerated. I want to be included and embraced. And so I think going from this very neutral language around like tap dancing around the issue and talking about tolerance to addressing racism explicitly has been really great to see and has made me proud to be a member of the organization. And then recently, just a month ago, we published a policy statement on eliminating race-based medicine. And so for those of you who aren't clinicians on the call, there's been a lot of discussion, mostly in adult patient populations, particularly around things like EGFR, which is your glomerular filtration rate, which has had a correction based on assumptions around muscle mass if you are Black versus other races. And the challenge is that when you do these corrections, we know that like end-stage renal disease, there are significant disparities in Black patient populations. And it potentially, when there's this correction, it results in delayed diagnoses for patients. And recently, we've been kind of called to task thinking about how this impacts us in pediatrics with some things like including race in our decision-making around urinary tract infections, as well as race in our decision-making around risk factors for jaundice. And the Academy has taken a stance that race is a social construct and not a biological construct. And although we want to have a race consciousness, right? So we don't want to be colorblind and say that race doesn't impact our decisions. We want to understand how racism impacts our patient experiences and how racism contributes to disparities. But we don't want a patient's race to determine who's getting worked up for certain things and potentially contributing to inequities in care. So this is another good example of how research can be used as a tool for advocacy. And then the question is, what's next? And so maybe you guys will have some answers for me, but I'll say I'm in this phase of my career where I've kind of moved past documenting disparities and I'm leaning into doing more work around fixing the disparities through interventions and research, as well as through policy, doing some of that work with academic organizations. Would love to hear from people who are here about how to lean into doing some of that work locally here at UC Davis. And then I'll also just say, and this will probably benefit the trainees and junior people on the call too, as I'm doing this kind of transition from early career to mid-career. I just have this sense that the work that I've done has been good and it has made an impact, but I feel like I'm just scratching the surface. But I still can't figure out what's under the surface and how to get there. So I'm hoping that at some point this summer, I'll be able to carve out some time to to like shut off the clinical work and shut off like all of the writing and all of the studies and just really begin to think, envision, and dream about what's next so that I can use my voice to make the greatest impact possible. And I would love to learn how any of you who are on this call can be partners with me in that journey. So with that, I will stop sharing my screen and I will open it up to questions.
Thank you so much for a fascinating talk. If people have questions, please, I see a lot of virtual claps. Unmute and feel free to ask your question or write it in the chat and I can read it. So there's a question in the chat. Ellen, do you want me to read it or do you want to ask? It says, thank you so much for your time and energy. I have several questions, but I will start with this. For students interested in transitioning from basic science to academic medicine, how common it is for trainees to be supported in diversity, equity, science projects? And on that same note, what unique barriers exist when trying to juggle equity science projects and other projects, including clinical practice? Thank you, Ellen.
Sorry, I muted myself. Thank you for that question. I think that's a couple of questions in one. So the first part, if you are interested in transitioning from basic science to academic medicine, how common is it to be supported? And, I will say on my journey, I've both received an incredible amount of support in a lot of ways, and I have also encountered roadblocks in a lot of ways. And I think that has been true. And I joke for my trainees that I'm academically promiscuous. I'm out in these streets, right? So I was in one institution for medical school, then another for residency, then another for fellowship, and then another for my early career. And now I'm here at UC Davis. And that is, and I can't say that there's any institution that has been particularly egregious or one that has been particularly, like, I think academic medicine is academic medicine. And so I have received both lots of support in every place that I've been, and I have also encountered barriers in every place I've been. And so I think the key is that, particularly when you're doing work around equity, you are going to face barriers because it is going to make some people uncomfortable. So I'll give a couple of examples of barriers that I face. So for example, in the work that I did looking at the implicit bias with the residents, there was also a planned arm to do some work with medical students where we gave them clinical vignettes and measured their bias and looked to see if it was associated with differences in the clinical vignettes. And even though the IRB approved the study, in order to do research with the medical students, there was like a board within the medical school that had to approve it. And so I submitted the proposal and they said, well, just make these couple of changes and then we'll accept it. And I made those changes. And then they told me to make another few changes. And then I made those changes. And then, like 11 months later of them stringing me along, they finally got on a call with me and they said, so we're not going to let you do this study because if you find what you're looking for, you're going to expose that our medical students have implicit bias and so you can't do it, right? So so that was one example. Then when it came to publishing some of those studies on implicit bias, we were trying to do a press release to help kind of generate some buzz around it. And the institution that I was working in at the time, PR would not let me do a press release. And they put in an email that I couldn't do a press release on my research because it was a threat to the reputation of the institution. So those are examples of some of the barriers that I have faced. And so doing this type of work, you are probably going to face some barriers wherever you go. I think the importance is going to be that you have good mentors and good sponsors who are in positions of power who can help buffer you and protect you when those things happen, because they're going to happen. But having mentors and sponsors who are proactive, who are going to protect you, who are going to support you, who are going to help elevate your work is going to be the thing that's going to help you to continue to move forward, even when you have those barriers and those setbacks. And then there's another subpart of that question is barriers in juggling equity science projects with other projects, including clinical practice. And so I don't think that that's a barrier unique to equity science. I think that's just a barrier to being a clinician scientist. But also, like clinician scientists, we like to think like, oh, we're the hardest working people in the world. But the PhDs also have to juggle research with teaching, right? So they have to juggle research with teaching. We have to juggle research with clinical work. And it's always going to be a juggle anytime you're in academics, whether you're a clinician versus an educator doing research. You're gonna have to have that struggle and that balance. And I would say again, that's where good mentorship comes in, and having a balance of your mentoring team for people who can help you with some of that work-life integration. I'm sure there are others on the call who also are juggling, who might offer some suggestions as well for how they do their balance.
Yeah, absolutely. If anyone wants to pitch in, or ask some other question. Yes, Jeffrey.
Great talk, Dr. Johnson, and congratulations on, well, 30 days early, congratulations on the promotion.
Thank you.
How do you figure out what you want to prioritize? Because I imagine there's so many things you'd like to do, and you might have constraints on your time, your energy, your effort. How do you figure out what your priorities are, and have they changed?
So I'll say that Dr. Hodge is on my campus launch committee. So he one of the things that I do is I have a strategic plan that I've been doing since I was in fellowship, that I start the strategic plan off with my mission and vision. Let's see if I have it. It's like always on my screen. So I'll pull it up, and I can actually maybe even share it with you guys so that you can see as an example. So this is, so I literally do this every year. I last updated this in April, and it's something that I have for myself as well as for my mentors, but it starts off with my mission statement. So my mission, my life's purpose is to make a positive impact on my community through excellence and compassion in clinical care as a PEM physician, through research and advocacy, focused on reducing avoidable disparities, dismantling structures of racism, and helping all children achieve their highest level of health and well-being, and lifting as I climb to support the next generation of Black and Latin physicians, researchers, and advocates to address, to advocate to achieve success, and advocates to achieve success. And so then it has like my 5-year goals, my 1-year goals, my ongoing projects. But I put this as an example because starting with my mission is where I start with prioritizing. So any request that's asked of me, I have to look to see if it's aligned with my mission and vision. And if it's not, then I shouldn't be doing it. Another way, particularly early in my career, I had more of a no committee. I don't have that as much now. Maybe I should because I'm doing too much. But earlier in my career, I had a no committee. So anytime somebody asked me to do something, I would never give an answer immediately. And I would always say, like, I need to talk to my mentors, because some things look like really good opportunities that are actually just really huge sucks on your time, that are distractions from what's important. And some things look like, oh my goodness, I don't want to do this, but strategically, they're really important to help you advance your career and advance your mission. And early in my career, I couldn't distinguish between the two at all, pretty much. And so having mentors who I trusted, to be who were not directly involved in those things, right? So they didn't have a conflict of interest, who could advise me on what to say yes to or what to say no to. And then the other thing that I did early in my career was I asked my mentors for permission to say no to anything I wanted to and to use their name as the reason why, without even asking them. So if it was something that like I just didn't want to do, like I would have permission to say like, oh man, like I really want to do this, but so-and-so said that I can't because I need to focus on X, Y, and Z. And so it was easier for me as a junior person to blame somebody else for saying no because I felt uncomfortable saying no. I think now I'm in a position where I feel better saying no myself. But earlier on, it was helpful to be able to blame other people for my no's. And so those are some of the things that kind of help to guide me. So having a mission, and really like looking at what's on my plate at all times so that I can look to see, am I aligning my time with what I see as valuable? And then having a panel of mentors who can be that no committee to tell you what to say yes to and what to say no to.
That's an amazing answer and great advice for young and old, for all of us. I think you have a mission statement. I'll try to follow your advice. And I see a question, a hand up by Laurel Beckett.
Hi, it was a great talk. I particularly appreciate it, as you know, I've worked in areas across a wide field, and the disparities in health are just obvious. I'm a biostatistician. I'm distinguished professor emerita. I'm no longer head of the department. So in principle, I have more time to think about these issues one of the things that we're doing in biostatistics in our division is having a running workshop on algorithmic bias and trying to address issues in which our efforts as analysts to be objective and to identify areas where there are disparities often make things worse. That if you have racial bias in your algorithms, that on the one hand you can help to identify problems, as your research has done in so many areas in pediatrics, but on the flip side, we can also come up with algorithms that make things worse by, for example, I think in breast cancer, you're probably familiar with some of the issues around breast cancer algorithms that say, well, we shouldn't put this person at an elevated risk because they're in a group that might have these things that might be treated as markers, but against the background of, quote, adjusting for race. So do you have thoughts on how we as statisticians, epidemiologists can balance between these two goals, and working with someone like you who's an expert in medicine and is working in this area? Are there ways we can try to improve our ability to detect disparate outcomes without making them worse?
So thank you for that question. I think that ties into that last slide that I had talking about race-based medicine. So that's exactly what it is, right? So exactly. I think it's important that we look at race and ethnicity in our research because we need to identify disparities that exist. But then there has been that challenge where we have inserted it, instead of inserting it as a social variable, we've inserted it as a biological variable that we now correct for in things like looking at who should get a vaginal birth after C-section and some of these other things. So I think the first step is like policies like the AAP, right? Coming up with these guidelines saying that we're eliminating race-based medicine, because this, and even when it comes to this, I'll say that myself, like I trained in the same medical schools everybody else trained in, right? So, so I was taught these same things. These things were a part of my clinical practice as well. And I had a lot of unlearning to do when it came to this topic and recognizing the potential harm that could come from it. So I had to do a lot of educating of myself and a lot of unlearning. And so I think that when these policy statements come from these big national organizations, it helps to prompt other people to be able to do that too. So I think that's important. And I'll also say that, I started the discussion off just talking a little bit about like my lived experience and how it shaped my research. And I think that another part of the solution is that we just need a more diversity of voices at the table, because we all have blind spots. I have my own personal blind spots, right? And so it's great collaborating with other people who can help me see my blind spots. And I think when it comes to investigators who aren't doing equity research, they have a lot of blind spots when it comes to, potential harms that things can cause. And so having diversity of perspectives at the table, I think, is going to be a part of the solution, so that you can, it's kind of like that Swiss cheese model, right? So that they can help prevent some of these harms that are being caused by having diverse perspective and voices to help us catch it.
Yeah, certainly. I've seen this sitting at tables where occasionally I'm found myself historically having to sort of speak up, because at least as a woman, I was someone who wasn't always represented, and saying, wait a minute, are you sure you're seeing? We don't have people with that perspective here at the table. So I think this is tremendously important. I really appreciate you bringing that out. And
Yeah, so we don't have people at the table, and I think that's a part of the problem. So I think that we need to make more efforts for getting people at the table. And so Campos is one of those programs that is trying to help do that by trying to help to increase the diversity of our workforce, but getting more people at the table. But you're right, we also can't just put the burden on the few Black and brown people who are in our institutions to be the ones to stand up. So how do we also make sure that that others who are in positions of power are doing the work themselves to learn and unlearn themselves so that they can also be voices to speak up when it comes to these issues.
Appreciate that. And thanks for your perspective on the ability to reduce race-based medicine practice and turn that into health-based practice and outcome-based. So, and you probably know, you probably know Dan Tancredi.
Oh, yeah. Mm-hmm.
Yeah, so Dan's my husband, so.
Oh, nice. Awesome. Yeah, Dan is he's the statistician for our department. And so
yes,
I will say I can give a little shout out to the department. I talked a little bit about our diversity committee, but which is chaired by Kara Tolles, who's now on this call. And the diversity committee has a couple of great things about the diversity committee. One is not just made up of the 3 Black faculty that are in the emergency department. So it is actually a heavily populated committee. And it's great to see that my colleagues recognize that addressing issues around diversity, equity, inclusion is a shared responsibility and not just a responsibility that needs to be burdened by the people that are most impacted by it. And then the other thing is that there are several subcommittees. So there is an advocacy committee, there's a clinical operations committee, and there's a research committee, medical education, but the research committee has begun doing work on beginning to look, going through this process that I've gone through in my career of first starting off at identifying with a goal of working towards understanding and reducing. But Dr. Tancredi is the statistician who helps out with a lot of the ED-based research. He has some FTE to support our department. And so he has supported some of that research where one of the first studies, one of the ones that there's one looking at abdominal pain, there's one that I'm involved in now where we're looking at racial and ethnic differences in who gets chemical restraints when they come in with mental health emergencies. And so it's been great having a statistician so that, we bring a clinical perspective, right? And then there's an equity perspective, but also making sure that there's a statistician to help out with that as well. It's been really helpful.
Yeah, I work a little with your department, mostly with Garen, so.
Oh, lovely. Garen is also on my mentoring team, and he is he's phenomenal. He's helping me on that last pillar of my research of focusing on how I can translate my work into policy and advocacy. So he's been a really helpful member of my mentoring team.
Thank you so much, and I look forward to hearing more about your research and probably some from Dan too.
Thank you. Tell Dan we said hi. The emergency department loves him. He's really great.
Thank you for that question. I was interested in the first part of the entire question and the answer, but the first part of the question, we had the advanced symposium less than 2 weeks ago, and we were addressing equity and ethics in research and data science. So in the context of the talk that we just heard, how can statisticians and data scientists look at the textbooks even? I mean, what doctors are being taught, like historically, there's a lot of bias embedded in those texts. Can we use the tools from data science and statistics, computer science to bring that to the surface and start excising those biases from the literature? That's a different angle from what we just heard. And yeah, the multicultural perspectives are essential, having the different people sitting at the table and not segregating the diversity initiatives to just a few minority faculty who are, in theory, the ones who will benefit, because that's not true. We all benefit from those initiatives. So yeah, thank you for that question and that answer. Any other questions?
Yeah, Mariel, in that line, that reminds me, I think that 2 months ago, I saw a talk with Dr. Kupiri Ackerman, Beckman Ackerman, that she's in the nursing school. And she was precisely, she even showed some pictures of textbooks in nursing. They were some having so many, I would not say implicit bias. They were overt biases. Like as an example, that African American has not that many nerve endings, so they don't perceive pain. But then there was another chart that they will say that African Americans, complain in the ER about pain, body is more because they want to call attention to themselves, like more like a psychological kind of aspect that they just wanted to show off, or drama queens kind of thing. And they will continue. That chart was mind-blowing because it would put like Jewish people, the Muslims, the Hispanics that are Catholic, the ones that are not Catholic, but there was nothing about white people, so everybody was having an issue with pain because they were either calling for attention, or they were drama queens, or they was just, they don't know what pain actually is. They just, just something minor. They imagine that it's a scale 10. But the white people was the norm because they were not in the chart, so when they complain about pain is true pain. So textbooks, right, that the idea that just a textbook will have something like that clinicians, nurses, pharmacists, dentists are trained already with that very explicit bias that you need to, as you mentioned, right, to eliminate in your training. You need to unlearn instead of building upon what you learn. So yeah, how we can do about that, how we can get more involved in editing books, even pointing it out if we're teaching a class, this is wrong, how to go back to change that language that is being presented to the students as the true and correct language in clinics and medical practice. Mm-hmm. Because for me, it's mind blowing that they will have, and that will it will not be a surprise then when they have the chart that you show about the race bias, if it's a child or an adult, it should not be a surprise because they have been trained like that, unfortunately.
Right. And so I think that that's an important point. I talked more about like kind of more the historical context of racism in medicine, but it goes all the way through the modern day context. And so like the biases that we have are by design, like we're trained to be that way in medicine. And I'll say, when I was a medical student, I feel old now, when we walked to work barefoot in the snow uphill both ways, we weren't, I'm so proud of this next generation, right? So, when these things, we had a lot of frustrations and things that were like, this doesn't seem right. And I think let me take an I perspective. I, as a medical student, did not feel empowered to speak up because I was afraid of retribution. And I think that this next generation of medical students, they're not taking no stuff. And so there are organizations like White Coats for Black Lives who actually do grading of medical schools around things like, are they, practicing race-based medicine versus race-conscious medicine, and thinking about ways that we can help improve the medical education system. And so I'm glad to see this next generation really standing up and just encouraging us to not continue to accept the way things are. But I think is it an Angela Davis quote, like, I'm no longer accepting the things that I cannot change, but I'm changing the things that I cannot accept. And that's what our medical students are doing. They're changing the things that they can't accept. And so I think it's really important for us as faculty members to make sure that we are providing support to them so that they don't get backlash, because they definitely can get repercussions in terms of their evaluations. But also when we're the ones that are in the classroom, it's really important that we make it clear that race is a social construct, for example, and not a biological construct. And we really call the task all of our medical educators to adjust their practices and give them feedback when they're not doing so.
Thank you. There's one more question in the chat, so maybe you can address it quickly before we finish the call, from Ellen, who doesn't have a mic. To understand the root cause of a disparity, do we need to take one step beyond assessing implicit bias and determine which specific policies, teaching, stereotypes that are part of structural racism are responsible for creating those biases, especially if they exist within science and/or medicine? Or is structural racism so pervasive that pinpointing specific causes of bias is impossible?
So I think that it's a both and approach. So I think when it comes to implicit bias, what we do know that I didn't touch on was that, for a while, people like to think that our implicit bias was hardwired. And so it's like, well, I'm 50 years old and I grew up in Alabama and I have these biases and I can't change them. But now we know that those biases can be changed over time. And so I think that when we think about addressing these issues, there are some evidence-informed strategies that can be used to address your biases. And so some examples are one is increasing cross-cultural contact, right? And so humans just have a tendency towards homophily, right? And we tend to just hang out with people that look like us and act like us because it's more pleasant to be around people you don't have to argue with all the time because they're different from you. But if we can, and because of that, many of our opinions about groups that are different from ours are informed based on stereotypes. And so how can you increase your opportunities for cross-cultural contact to begin breaking down those stereotypes? Other suggestions are focus on individuation, right? So in patient care, really try to focus on, so for me, the example that I give is every patient that I take care of in the emergency department who's developmentally able to do it, I ask them what grade they're in, like what their favorite color is, what they want to be when they grow up. And what that does for me is instead of seeing them as like the asthmatic in room 6, I'm able to see it as, this is Johnny who has asthma, but, who wants to be a firefighter when he grows up. And I'm able to see them as a person and as an individual and focus on those individual characteristics instead of their disease and also instead of just like their race or their ethnicity or their gender. And so there are some evidence-informed strategies that can be deployed for addressing our bias. And so I think anti-bias training is important, but anti-racism training is also important. And so in addition to focusing on you as an individual provider and your own personal biases, we also need to address the systems that are in place that continue to perpetuate inequities. And Claire, and I think that begins with looking internally at what are our policies and what are our procedures and evaluating them with an equity lens to see are there policies that inadvertently perpetuate and contribute to disparities in care outcomes for our patient populations. Thinking about how we are supporting our community and serving as an anchor institution and reinvesting in the community that surrounds us so that we can address some of those like structural determinants of health that impact our patients. So I think it's a both and. I think that there are implicit biases on a personally mediated level that need to be addressed, and then there's also structural racism. And unless we address both, we're not going to be able to address the inequities that we see in patient care.
Thank you. Thank you very much. So with that, we'll close the campus colloquium. Thank you so much again. Congratulations on your promotion. Sorry for promoting you a month earlier. I actually read it. I'm like, that's true. That's not right. But it was amazing. So congratulations. Congratulations on the Chancellor's Achievement Award that you received just a few weeks ago.
Well, thank you so much for supporting me and for being a part of the community of both interpersonal support through things like the colloquium, as well as financial support, putting your money where your mouth is, helping to support URM scholars to be successful here at UC Davis. So thank you for all that Campos is doing to support us.
Wonderful. Thank you. Thank you so much. And thank you everyone for being here. We'll see you next year.
See you next year.
Have a good summer. Bye everyone.